This presentation is going to go over gastrointestinal drugs. First, we're going to talk about the drugs for peptic ulcer disease. First, let's talk about the pathogenesis of peptic ulcer. We have defensive factors and then we have aggressive factors. And peptic ulcer develops when there's an imbalance between the mucosal defensive factors and aggressive factors. The major defensive factors that we have are mucus and bicarbonate. The major aggressive factor, these are H. pylori, NSAIDs, gastric acid, and pepsin. Okay, so they're on different teams, and when we have an imbalance, things go wrong. Now, mucus is secreted continuously by the cells in our GI mucosa, and this will help to form a barrier protecting those underlying cells from any acid and pepsin. Bicarbonate, or bicarb, is secreted by epithelial cells of the stomach and duodenum, and most of our bicarbonate remains trapped in the mucosal layer, and this is going to help neutralize, because bicarb is a neutralizing agent. It's neutralizing any hydrogen ion, okay, so the base is combating the acid, and any hydrogen ion that penetrates that mucus, bicarbonate is there to help. It's produced by pancreas and secreted into the lumen of the duodenum, and this is where it neutralizes acids that are delivered from the stomach. It's also important to think about the blood flow. Adequate blood flow to the cells of the GI mucosa is going to be essential because this is going to help with the integrity of that mucosal lining. If the submucosal blood flow is reduced, then we are going to have ischemia in that area, and this can lead to cell injury. If we have cell injury, this can cause vulnerability to attack by acid and pepsin. And lastly, prostaglandins. They also play an important role. They stimulate secretion of the mucus and bicarb, and they promote vasodilation, which is going to help bring in that submucosal blood flow and help maintain the level that we need. Without prostaglandins, we don't have barriers of mucus and bicarb. Therefore, prostaglandins are going to provide additional protection from the suppression and secretion of gastric acids. Now that we've talked about the defensive factors, let's talk about the aggressive factors. And first, we're going to start up with H. pylori, or Helicobacter pylori. And this is a gram-negative bacilli colonizes in your stomach and duodenum, and it takes up the space between epithelial cells and the mucosal barrier, which is there to protect the cells. But the bacterium, H. pylori, will escape the destruction by acid and pepsin. And when it establishes there in your GI tract, it can live there for decades. Why do we think that H. pylori causes PUD? Well, we don't actually really know, but we have some general ideas. What we do know is that 60 to 75% of our patients with PUD have H. pylori. We also know that duodenal ulcers are more commonly found in patients with H. pylori. We know that if we get rid of the bacterium, H. pylori, it will promote sort of healing, and those patients that we are successful in removing H. pylori, they have a lower incidence of reinfection. 80% of people that have an ulcer that still have H. pylori, they are going to be reinfected. Or there'll be a reoccurrence of an ulcer. Those patients, if we are successfully able to remove H. pylori, eradicate it completely, then their reoccurrence level is only about 10%. The likely possibility of why H. pylori promotes ulcers is through enzymatic degradation of that protective mucosal layer. We also know that cytotoxins injure mucosal cells, and infiltration of neutrophils and other inflammatory mediators can also break down a mucosal cell. We do know that H. pylori produces urease, and this is an enzyme that will convert and form carbon dioxide and ammonia, and both of these things can be potentially toxic to your gastric mucosa. Additionally, we do know that H. pylori plays a role in the promotion of gastric cancer, and it's actually been declared a type 1 carcinogen by the International Agency for Research on Cancer. There's a very strong association between H. pylori infection and the presence of MALT lymphomas. MALT stands for mucosa-associated lymphoid tissue, MALT. So we know that with patients with MALT lymphoma, if we can get rid of H. pylori, the tumor regression rate is high. higher, about 60 to 90% in those cases. There has been a study of H. pylori, and if we can treat H. pylori, it reduces the risk for gastric adenocarcinomas by about 40% after 15 years. So it is an important bacteria to remove. Now, sometimes, in some cases, people have H. pylori and they don't know, and they're just asymptomatic. But it doesn't mean that we shouldn't still get rid of it if it does link to adenocarcinoma later in life. With NSAIDs, it's pretty clear. The underlying cause of many gastric ulcers and some duodenal ulcers are NSAIDs, and this is, as we discussed earlier, it inhibits the biosynthesis of prostaglandins. And so when we inhibit prostaglandins, we are decreasing the submucosal blood flow, suppressing secretions of mucus and bicarb. And we know that those are defensive mechanisms. We need those. They promote secretion of gastric acid. Furthermore, NSAIDs can irritate that mucosa directly. It can just bypass the mechanism of the biosynthesis of prostaglandins and just irritate the mucosa. And these ulcers are more likely connected with long-term high-dose therapy NSAIDs. Now, gastric acid we need for peptic ulcer generation. In the absence of acid, you can't form an ulcer. So there is a direct link from our gastric acid to ulcer production. It injures your cells of your GI mucosa indirectly because it activates pepsin, which is a proteolytic enzyme. And in most cases, this hypersecretion of acid all by itself is not enough to cause ulcers. In most patients with gastric ulcers, that acid secretion is not even elevated, or sometimes it's even reduced. Among patients with duodenal ulcers, only a third produce excessive amounts of acid. So what do we learn from this? We can actually conclude that most patients with peptic ulcers, the factors in addition to acid have to be involved, like H. pylori. Zollinger-Ellison syndrome. This is a primary disorder in which there is a hypersecretion of acid alone, and this causes ulcers. And this syndrome is caused by a tumor that secretes gastrin, which is a hormone that stimulates gastric acid production. Now, the amount of acid produced is so large that it will overwhelm your defense factors. And we know that once it does that, it just puts you more at risk for peptic ulcer. Zollinger-Ellison syndrome is rare, and it only is connected, though, to 0.1% of all duodenal ulcers. And then the next two are pepsin and smoking. Pepsin is a proteolytic enzyme present in all our gastric juices, and just like our gastric acid, it can injure the mucosal layer and all the unprotected cells of the gastric and duodenal mucosa. Smoking delays ulcer healing and increases the risk for the reoccurrence of ulcers, and it can reduce the beneficial effects of any anti-nuclear medicines that we're using to treat. It can reduce secretions of bicarb, and it can actually accelerate gastric emptying, which would then deliver more acid into the duodenum. Alright, so now that we reviewed some of the basic pathophysiology, let's talk about the anti-ulcer drugs. The first group are the antibiotics that are used, and then we'll talk about the anti-secretory agents like the proton pump inhibitors and the H2 receptor blockers. We'll then touch upon mucosal protectants as well. So from this classification, you can see that the drugs are going to act on three basic ways to promote ulcer healing. First, we use antibiotics to eradicate H. pylori. Many times we are, per the clinical guidelines, going to use at least 2 antibiotics, and then we'll use a PPI. And what we're trying to do is reduce the gastric acidity. And then lastly, we'll enhance the mucosal defenses, and that's when we'll use the drugs that are in the other category, like sulcrophate and misoprostol. So how do we decide on the drug selection? remembering that the first priority is eliminating Helicobacter pylori or H. pylori because these are H. pylori associated ulcers. So any patient with gastric or duodenal ulcers with the documented H. pylori infection should be treated with antibiotics. And again, we're using at least two, and sometimes there's triple therapy depending on how difficult it is to eradicate this H. pylori. And this recommendation applies to patients with newly diagnosed PUD, recurrent PUD, and even those that have associated ulcers due to NSAID use. And to help promote healing and relieve symptoms, we'll add an anti-secretory agent, and this should be given along with the antibiotic. Many times, you can give a proton pump inhibitor, which is the first choice, and you can use something like omeprazole. Sometimes H2 blocker or a histamine 2 receptor antagonist is picked as well, like cimetidine. Now, if there needs to be prophylactic therapy, then many times we're picking a PPI like omeprazole, which is preferred. Now, misoprostol is also effective, but many people complain about diarrhea as being a side effect. We do not recommend for prophylaxis H2 receptor blocker, sulforaphane, and antacids for NSAID-induced ulcers. With NSAID-induced ulcers, we can treat it with any of these ulcer medications, but the H2 receptor blockers and the PPIs are the ones that are preferred. Remember, we're not using an antibiotic in this case because it wasn't due to bacteria like H. pylori. And if possible, the NSAID that started the cascade and events to create the ulcer in the first place should be discontinued, and this is going to accelerate the healing. Now, if the NSAID can't be discontinued for some reason, then giving a PPI can help promote healing. I'm going to repeat this one more time. Antacid, sulforaphane, and H2 receptor blockers, they are not recommended. Well, how do we know if this is actually working? How do we evaluate? And what we're going to do is monitor our patient for the relief of pain. We can also ask for imaging to make sure that the site of the ulcers are actually getting better. But unfortunately, this evaluation is seldomly straightforward because even with the cessation of pain and the disappearance of the symptoms, the ulcer rarely coincides with the symptoms itself. So in most cases, even though the pain goes away and the patients stop complaining about pain, it doesn't really mean that there's full healing. So sometimes, even though you're asking about their own subjective account, you may need to back it up with endoscopy or other radiology diagnostic tests. Also, the other side of this can be true. If you order those images and it looks like everything has healed completely, your patient can still complain of pain. I just want to remind you though to check back and to evaluate for H. pylori. You have to determine what method is going to be best, and usually it's several methods. The breath test for H. pylori, you can also, or a serologic test, stool test, and even a microscopic observation by getting a biopsy sample. And here on this chart, you can see the different classifications, starting with the antibiotics, and then we have the anti-secretory agents, H2 receptor antagonists, proton pump inhibitors, and then we have mucosal protectants and antacids. So we have sulforaphane, misoprostol, which is an anti-secretory agent, but it enhances the mucosal defense. And then the antacids that are most common are the aluminum hydroxide, calcium carbonate, and magnesium hydroxide. And remember that these are reacting with the gastric acid to form neutral salts, and it will help combat the acidity. I do want you to take some time and learn the drugs within each drug class, and uh, pay attention to the mechanism of action specifically. Now we're going to move on to laxatives. Now, laxatives are used to ease or stimulate a bowel movement, and these agents can either soften your stool, can increase your stool, help you to have more motility so that stool passes through the intestines quicker, or it's actually going to facilitate evacuation from the rectum. There's 5 classes of laxatives that we will discuss. There's the bulk forming, the surfactant, stimulant, osmotic laxatives, and then there's a classification kind of lumped up. We call this the miscellaneous. Misuse of laxatives really comes from not understanding the different classes, what they are for, so like the mechanism of actions, and many times patients just assume all laxatives are the same and they're going to provide the same type of relief. But before we talk about laxatives, we have to distinguish between the two terms, laxative effect and catharsis. First, a laxative effect is when we are able to produce a soft form stool over one or more every day. Catharsis is when we need something to happen fast. It's the prompt fluid evacuation of the bowel. It's fast and it is intense. All right, so to review, we are going to cover the 4 major categories, and then of course we talked about the miscellaneous as well. Remembering that they're categorized by the mechanism of action, and this should help you to understand the classification. The first one we'll talk about is the bulk forming laxatives. These are your methylcellulose, your psyllium, and it works directly on the small intestines and the colon by absorbing water and softening and enlarging the fecal mass, and this is why they're called bulk forming. And it additionally will cause fecal swelling, promoting peristalsis. The surfactant laxatives work also in the small intestines and the colon. These are your docusate sodium, docusate calcium. It has a surfactant action that's going to soften your stool by facilitating the penetration of water, and it's going to cause secretion of this water and electrolytes into the intestines. The stimulant laxatives, like bisacodyl and senna, work on the colon, and castor oil will work on the small intestines. They have 2 primary goals. First, to stimulate peristalsis, or that movement of stool. And secondly, it's going to soften stool by increasing secretion of water and electrolytes into the intestine. And this is going to decrease water and electrolyte absorption. Osmotic laxatives. These are your magnesiums and your sodium phosphate, polyethylene glycol, which is more commonly known as Miralax, and this is what we use for a clean out before colonoscopy. Lactulose will also be within this osmotic laxative category. And osmotic laxatives will work on the small intestines and the colon, and this is where it takes an osmotic reaction, so it's pulling in water, it's trying to retain that water into the small intestines and colon. By softening the feces, it's going to also help promote a daily stool, and the fecal swelling will promote peristalsis as well. So very similar to the action of bulk forming laxatives. And then our miscellaneous laxatives. These primarily work on the small intestines and colon as well, except for the sodium picosulfate, magnesium oxide, and the anhydrous citric acid, which only works on the colon. The first 3, basically you are using this as either an added drug to your other drug regimen for laxatives, or sometimes you can use them by themselves, but they are not used as often as the first 4. Now, lubiprostone, this is going to open your chloride channels in the intestinal epithelium, and this is going to increase motility and secretion of fluid into the lumen. So therefore, we will promote having a stool daily or multiple times a day and a soft stool because we have that secretion of fluid. Flecainide, this will assist in the regulation of the intestinal fluid secretion and motility directly by increasing your chloride and your bicarb in the lumen itself. A polyethylene glycol electrolyte solution. This is similar to the osmotic laxatives, and you can see the polyethylene glycol in both, but this has electrolytes, remembering that sometimes you will lose some of that electrolyte absorption. So this classification of drug is trying to preserve that. And then lastly, the sodium pycosulfate and the others within that category, these will stimulate colonic peristalsis and its drawing waters into the GI tract. More importantly, to remember the first four classifications, as we don't use the miscellaneous laxatives very much. Now, from a clinical perspective, we also not only want to know the laxatives by their mechanism of action, but it's important to understand the laxatives by their therapeutic effect. So, how fast are they going to work? And how effective are they on the stool? And when these properties are considered, most of the laxatives can be then divided into three groups. There will be the first group, which will allow the production of watery stool within 2 to 6 hours, versus a semi-fluid stool within 6 to 12 hours, or a soft stool with 1 to 3 days. And so depending on how severe the constipation is, or how quickly you need to have a result, you will pick a laxative based on these three groupings. The other laxatives are the laxatives were in that other category, like lubiprostone, mineral oil, or glycerin suppositories, are worth mentioning a little bit more because they can be used um, in some patients that it's just really difficult to have relief of constipation based on the more common laxatives. The first one we will talk about is lubiprostone, and this is a new type of drug. And again, it's working on the chloride channel activators, selective chloride channel activators. And what it's going to do is it's going to open or activate those chloride channels in the epithelial cell lining in the intestines. It's going to promote the secretion of chloride-rich fluid into the intestines and enhance the motility of the small intestines and the colon together. So what will you get as a result? Spontaneous evacuation of semi-soft stool, and usually a patient can expect this to happen within 24 hours. The reasons why we would use this over the other ones are, first, a patient has chronic idiopathic constipation. It cannot be relieved by the other laxatives. The second one is this could be used for irritable bowel syndrome with constipation. Remember that irritable bowel syndrome can also be with diarrhea. So we're using this with irritable bowel syndrome with constipation in women at least 18 years old or older. And lastly, it's a it's a good new medication that can be used for opioid-induced constipation or chronic non-cancer pain. In addition to the constipation, in the early drug trials, it was also known to not only reduce the constipation severity, but reduce the symptoms of bloating and discomfort. It should not be used in pregnant women unless the benefits are deemed to outweigh the potential risks of the fetus. Okay, so in animal studies only, it was shown not to be teratogenic, but again, you don't want to use it unless there's really no other options. Um, we did find that even though in um, some animal studies it was not teratogenic, when this drug was given to guinea pigs in doses more than 100 times the human dose, then it did cause fetal loss. But again, that was 100 times the human dose. Also, interactions with other drugs have not been studied yet because it is a new drug. And because this drug is poorly absorbed and it does not alter the activity of cytochrome P45 drug metabolizing enzymes, we really don't know yet um, if there's going to be any reactions, but it's very low likely because there's no alteration in cytochrome P450. Now, I did mention polyethylene glycol really quickly as a bowel cleanser for colonoscopy. And so I did want to jump into that just a little bit more because there are other options. For colonoscopy, which we know is the most effective way to detect colorectal cancer, and we follow the clinical guidelines here in the US for colorectal cancer. So when you are 50 years old, you need to have a colonoscopy. And depending on your family history, you may need one sooner than that. So before the procedure, the bowel has to be cleaned out. And this is to help with visualization with the camera or the scope. And there are three types of bowel cleansers that we can use, or bowel cleanout methods. The first one is sodium phosphate. The second one is a combination of sodium picosulfate with magnesium oxide and citric acid. And the last one is polyethylene glycol plus electrolytes. And sometimes it is termed PEG ELS. And these products are isotonic with the body fluid, so they don't alter your water electrolyte status. But in contrast, the sodium phosphate and the combo products are hypertonic, and they can actually cause dehydration and electrolyte disturbances. The sodium phosphate products can also cause kidney damage, so you don't want to use those if your patient already has an underlying kidney problem. So again, those are the sodium phosphate products. But despite that they have a greater potential for side effect or for harm, these products have better patient acceptance because patients hate taking the PEG ELS products because you have to drink so much of it. There's so much volume of liquid that you have to actually take to make it work. And the sodium phosphate products don't have that. But again, you want to counsel your patient or teach your patient that just because it's a little bit easier to do doesn't necessarily mean that it's not without risk. And some of those risks are electrolyte abnormalities, renal impairment, and hypovolemia. Remembering that it is a drug that is hypertonic. So you will lose fluid, causing dehydration and electrolyte disturbances. And you can see here on this chart how much you actually have to take of the Go Lightly or the polyethylene glycol plus electrolytes. 4 liters as opposed to taking a sodium phosphate, tablet with some clear liquid. So again, know the pros and cons of each of the medications and what your patient can expect. Now, the combo product called Prepopic. This is a 16.1 gram mixed package, and you put it in 5 ounces of water in the evening before the colonoscopy, and then you take another 5 ounces the morning of the colonoscopy. There's a few more drug classes that we will review in talking about the other GI drugs. These are the antiemetics, antidiarrheals, drugs for IBS, and drugs for inflammatory bowel disease. You can see here on the chart the antiemetic drugs by class, trade name, and dose. And we'll be looking in a few minutes at a chart that will talk about the mechanism of action as well. So, under the serotonin antagonists, we have all the drugs that end with citron, so ondansetron. And the most popular is Zofran. And you can see we also have drugs like the glucocorticosteroids, and the common ones are Decadron or Solumedrol, otherwise known as dexamethasone or methylprednisolone. And we have the substance P or the neurokinin 1 antagonists. A common one here is Emend, which is a aprepitant, and we also have benzodiazepines that can be used as well for antiemetic properties. And the popular one here is Ativan or lorazepam. And the last class that we'll look into are the dopamine antagonists. And the ones that we are looking at, the most common one is the phenothiazines. And then we have some other ones that are produced in generic form only. And another one that you should be familiar with under the dopamine antagonist classification is Phenergan, which is promethazine. This is something that we use readily in the hospital as well. We can also use butyrophenones like haloperidol or Haldol. We can use Reglan, which is metoclopramide, and cannabinoids can also be used. The more popular one is Marinol. Now that we've had an overview of the different type of medications in the classes, let's actually look at the mechanism of antiemetic action associated to each class. The first one is where Zofran is going to fit under, and it is a serotonin antagonist, so the mechanism of action is actually in the name. It's going to block serotonin receptors on the vagal afferents and the CTZ. The CTZ are the chemoreceptor trigger zones for MSS. Glucocorticoids can be used, like Decadron, for chemotherapy as well, and the action really is unknown on how glucocorticoids work to reduce antiemetic effect. Another one that we can use for chemotherapy are the substance P, the neurokinin 1 antagonists, and they will block the receptors for substance P, neurokinin 1 in the brain, and this will reduce that feeling of nausea and dizziness. The dopamine antagonists, they're going to block dopamine receptors in the chemotherapy trigger zone as well. It's a great drug to use for chemotherapy, post-op, or just in general. The cannabinoids we use only for chemotherapy. Again, this is another one where we don't really understand the mechanism of action, but we believe that it activates the cannabinoid receptors that are associated within the vomiting center. The last two classes are used for motion sickness. Scopolamine is a transdermal patch that you can prescribe. Patients like to use this maybe if they're going on a boating trip or they're going to be like on a cruise. It's a good one to prescribe. It's an anticholinergic, and we know that anticholinergics block the muscarinic receptors, but specifically here the reason it works is because it's blocking those receptors in the pathway from the inner ear to the vomiting center. The same thing is happening with the antihistamines that are also used for motion sickness, except in addition to the muscarinic receptors, it's also blocking the histamine 1 receptors, again in the pathway from the inner ear to the vomiting center. So please know the difference between the ones that we use primarily for chemo, the ones we use primarily post-operative reasons, and those used for motion sickness. I do want to get into scopolamine just a little bit more, just because you may not be familiar with this drug. It is the most effective drug for motion sickness, for preventing and for treating motion sickness. And the benefit really is because we're suppressing that nerve traffic in the neuronal pathway that's connecting your vestibular apparatus of the inner ear. Remember, that's where we get our balance. And it's connecting those pathways to the vestibular apparatus and the vomiting center. And the most common side effects, though, because it's a muscarinic antagonist, we're going to get dry mouth. Sometimes patients will complain about blurred vision, and this is one that's going to make you drowsy. Now, there's some more um, side effects, some more severe side effects, but they are less common, are urinary retention, constipation, and overall disorientation. And I've seen a patient with this effect of just being really disoriented. So, of course, you wouldn't provide that type of antiemetic a second time. It can be given in an oral and a sub-Q dose, but transdermal dosing is pretty easy to do. It's an adhesive patch and it contains the scopolamine, and you put it just behind the ear. Now, anticholinergic side effects with these transdermal patches are a little bit less intense than if you were to give it orally or with the sub-Q type dose. The antihistamines that you can use, like Dramamine, which most of you are pretty familiar with, this is an antihistamine, and many times you don't realize that that's the class that it's under. These drugs are going to block that receptor for acetylcholine in addition to the receptors of histamine. So we put them under anticholinergics. It's going to suppress the motion sickness by blocking the histaminergic or the H1 or histamine 1 and the muscarinic cholinergic receptors. Same thing in the neuronal pathway that connects that inner ear to your vomiting center. What is the most prominent side effect? Sedation. It makes you really tired. So many times, especially when you're on vacation and you are going to be on a boat or fishing or something like that, patients like to take Dramamine. However, it does make them really tired, and this is because it's blocking the H1 receptor. The side effects are pretty similar to scopolamine. You're going to have the dry mouth, blurred vision, urinary retention, sometimes constipation, and this is because it's blocking the muscarinic receptors. Now, the antihistamines are less effective than scopolamine, and actually you can get Dramamine over the counter, where scopolamine patches you would need, well, just scopolamine in general, you will have to get a prescription for it. Now, for the non-specific antidiarrheal agents, specifically using opioids is going to be the most effective antidiarrheal agents, and remembering that opioids cause constipation, so we're just trying to get the reversal action. When we activate the opioid receptors in the GI tract, the drugs are going to decrease intestinal motility, and then it's going to slow down that transit time. This is going to allow stool to stay within the intestines for longer, and absorption of fluid and electrolytes can take place. Also, when we activate those opioid receptors, it will decrease the secretion of fluid in the small intestines. Therefore, your stool is not going to be as runny. It's going to increase absorption of fluid and salt. So what's the net effect? You can produce larger stools with less water. So we're trying to reverse the effect of diarrhea. It also, in addition to reducing the fluid and the volume, it can also reduce the frequency of your bowel movement. Now, you have to pay attention to the dosing, though. You wouldn't dose it the same as, opioids for pain. When you are using the proper dose to relieve diarrhea, subjective effects and dependence aren't going to occur. So make sure you teach that to your patient and that they understand as well. Now, excessive dosing can elicit morphine-like effects, so you want to make sure you're not overdosing and you're only using the smallest amount necessary. It should be treated with an opioid antagonist like naloxone. Now, in patients with IBD, we do use opioids. However, you have to remember that it can cause toxic megacolon in patients with inflammatory bowel disease like Crohn's or ulcerative colitis. There are some non-specific drugs for IBS like antispasmodics and bulk forming agents. We also use antidiarrheals like loperamide and TCAs. And we have been using these to provide symptomatic relief. However, the American College of Gastroenterology, they actually said that most of these agents, there's not really good proof, but it's just been something that providers have been using, but we don't really have the backup for it. And actually, they said that the use of loperamide, which is commonly prescribed, is a bulk, and in addition to that, a bulk forming agent. You don't really want to use them because it didn't really give any more effect than the placebo for, all the symptoms of IBS. So really, again, there needs to be more research, but we don't have support at this time. Some studies suggest, though, that patients that have IBS, they can actually get relief from antibiotics or acid suppressants. So think of patients that have small intestine bacterial overgrowth, or what we call SIBO. These patients, when they have concomitant IBS and SIBO, if we treat with antibiotics, then we can reduce that bacterial colonization or bacterial load, and then therefore the symptoms of IBS will be reduced as well.